Hello and welcome to my presentation. My name is Clement Chiwaula. Today I'll be discussing maternal mortality and race in the United States and my problem statement. The United States has more women dying from pregnancy-related complications among the industrialized countries. According to the CDC, 700 women die each year as a result of delivery or pregnancy complications in the United States. And our discussion today will be based on a case study of Sharon Iving, which was published in the NPR with the title Black Mothers Keep Dying After Giving Birth. So Sharon Iving was an affluent, educated black woman who died as a result from pregnancy complications. Despite that, she could afford health insurance, had access to reproductive and obstetric care, was well educated, and had a very good supportive community around her. So this is the plight many black women in the United States face. And Sharon Iving's story is one of the best examples that highlights deeper issues that exist within our communities in terms of maternal and child health. So in the United States, in 2015, there were 40 maternal deaths compared to 12 for black women, compared to 12 maternal deaths for white women. There's so much maternal health disparities in the United States that contribute to the increased maternal mortality rates in the United States, in the world. And for black women, 22% are more likely to die from heart disease than white women, 71% more likely to perish from cervical cancer, and 23% more likely to die from pregnancy-related or childbirth-related causes. So, as I said before, the disproportionate toll on African Americans is the main reason U.S. maternal mortality rate is so much higher than that of other countries with the same economic index. Contributing factors for the increased maternal mortality rates are complex interaction of biological and health service factors. But for black women, is largely attributable to preeclampsia, abruptio placenta, and postpartum hemorrhage. Most of the black women, they also enter pregnancy with predisposing health conditions such as hypertension, diabetes, obesity, and heart disease. Social inequalities are some of the contributing factors, such as lack of basics of health foods, safe drinking water, neighborhoods, quality education, reliable transportation. There's also an issue of systemic racism that happens when women are receiving care in our hospitals. Black women have often complained about bias and feeling disrespected or devalued by medical providers. And the other issue is most of the black women live in low socioeconomic environments, which the hospitals also provide low quality services. And I applied the socio-ecological model to determine the evidence-based intervention that would help improve maternal health and reduce these disparities. And so the key issues that I found out were racial and gender discrimination, barriers to access prenatal care. At individual level, the barriers or the hindering factors were racial discrimination against black women, and thereby leading to receiving lower quality of care, or at sometimes for the black women, they get discouraged to attend antenatal or prenatal care. Interpersonal level, the promoting factors would be to improve or to encourage active and regular interpersonal communication between women and healthcare providers. The hindering factors are lack of satisfaction with healthcare services or healthcare providers. For example, 23% of women in Texas don't feel comfortable with their healthcare providers. Organizational level, promoting factors would be improving access to healthcare services for women. Most women have complained of lack of ability to care for health services, which is the biggest barrier to accessing healthcare in the United States. Community level, hindering factors with lack of reproductive healthcare facilities. For example, 15% of women in Texas have no immediate facilities where they can go to for their healthcare needs. And promoting factors would be to empower women and families and communities with information about danger signs of pregnancy, to ensure that women have a voice and also a role in decision making. At policy level, to promote increased to increase funding to federal states and local government to support implementation of mortality review boards, which I found out that it's a major problem because there's no standards for data collection and reporting of maternal mortality statistics in the United States. So proposed evidence-based interventions such as home visiting programs to target high-risk individuals, community-based interventions to empower communities and engage them in capacity building, and also monitoring and evaluation of health systems to improve quality of health care and effectiveness of delivery of care. And my proposed evaluation for these interventions is to conduct process evaluation to determine whether pregnant women are receiving improved care as a result of our interventions. Impact evaluation, we collect data before and after the studies and analyze it to determine if there's been an improvement in the quality of care, and also outcome impact to measure to assess if monitoring and evaluation have resulted in the improvement of maternal and child health and mortality rates. Barriers to interventions would be funding, resources and personnel, cultural differences, social and environmental factors. Our solutions would be to develop a budget and estimate costs of creating supportive relationships, interventions and maintaining it over time, identify human resource needs for the entire program in the planning phase, to develop culturally competent approaches and consider socio-economic and environmental factors. And I developed a logic model to go with these interventions, which would have the resources as staff, office space, funding, transportation, and partnerships. Our activities will include home visiting programs, community-based interventions, and strengthening health systems. Our outputs will be directed at educating and awareness, counseling, health screening, increased community engagement, and community knowledge about dangers of pregnancy and complications. And also we increase training of providers to deliver culturally competent care and avoid bias and discrimination. Our outcomes will be increased a number of women receiving prenatal care, receiving mental health support, reduced pregnancy complications, increased number of individuals engaged in community efforts, increase the number of women accessing healthcare service, and numbers of providers trained to provide culturally competent care to reduce discrimination. Our impact would be to improve maternal health outcomes and equity, efficient and quality healthcare. Thank you so much for being here for my presentation, and the following are my references. Thank you.